All right, welcome everyone to Emory in the Wake of Slavery and Dispossession. You are currently in the session Moving Forward, Acknowledging Our Past, Empowering Our Future. We'll have time for Q&A in the last 15 minutes, and we'll be taking questions from both the folks in the room and joining us virtually. And I will hand it over to Sheryl Heron to get us started.
Hello, everyone, and welcome to this panel, Empowering Our Future, which is really why we're here, but we have to acknowledge our past. It's my pleasure to introduce our panelists who are here today to really share with you what we believe and how we believe we need to move forward in the School of Medicine as it relates to this conference's theme around slavery and dispossession. With that, it is my pleasure to introduce our panelists. We'll first start with Sophia Stylianos, one of our medical students. She will be followed by Dr. Khaalisha Ajala, and I will then complete the conversation and with hopes we can engage you all. So thank you for being here. We shall begin, and I turn it over to you, Sophia.
Okay, thank you, Dr. Heron. So my name is Sophia Stylianos, and I'm a third-year medical student at Emory. I first want to say thank you to all of the organizers of the symposium, and also I want to say that I am very personally honored to be speaking on a panel with Dr. Heron and Dr. Ajala. Last year, I had the opportunity to research the history of desegregation at Grady Memorial Hospital, Atlanta's public hospital that trains about 1 in every 4 doctors in the state of Georgia. In the next 10 minutes, I will share stories that I hope will exemplify the direct thread of bias in medicine from slavery to the days of Grady's construction in 1892, to race-based medicine that is still practiced broadly in the present day. Okay, I'd like to start by sharing 2 stories. In 1931, Walter White, seen here, secretary of the NAACP, rushed to Grady Hospital in Atlanta, Georgia, to be with his injured father. His father, a Black man with lighter skin, had been struck by a vehicle and was admitted to the segregated medical facility, later known as the Grady's. He was admitted, however, to the white side, where the best doctors in the world in the hospital worked feverishly to save his life. When the hospital staff realized their admissions mistake, they rushed the ailing father across the street in a driving downpour to the Black ward. In his autobiography, Walter describes how his father was snatched from the examination table lest he contaminate the white air. When Walter arrived, he found his father amid overworked Black nurses, crowded wards, and giant cockroaches. His father died days later. 85 years later, in 2016, Alan Pan admitted himself to St. Joseph Medical Center in Houston, Texas, while having a bipolar episode. While admitted, Pan became increasingly delusional and refused to fasten his hospital gown. The nurses called for help managing Pan, and after a scuffle in his room, 2 off-duty police officers, serving as part-time hospital guards, shocked Pan with a taser, fired a bullet into his chest, then handcuffed him, an unarmed, undressed college student in the hospital as a patient. Alan Pan, who is of Haitian and Mexican descent, survived. But Pan's family grappled with the fact that his shooting was likely because of his race. Referring to police shootings of unarmed Black men, Pan's father admitted, "We never thought it would happen to us." The stories of Walter White's father and Alan Pan, from overt racism in the 1930s to the problematic use of hospital funds for armed private security, demonstrate an insidious yet ubiquitous concept: the intersection of racism and healthcare. The influence of racism on American medicine is impossible to separate from racist American politics dating back to our country's founding. Thomas Jefferson, author of the words, "All men are created equal," and lifelong slave owner, published his pseudoscientific views on Black people in Notes on the State of Virginia in 1787. In pondering differences between white Americans and enslaved Africans, Jefferson wrote the following: "Besides those of color, figure, and hair, they secrete less by kidneys and more by glands of skin. They require less sleep. Their griefs are transient." Jefferson did not seem to appreciate that perhaps the qualities he found peculiar were byproducts of the living and working conditions of chattel slavery. Further, he stated that a concrete conclusion regarding these differences requires many observations, even where the subject may be submitted to the anatomical knife, optical glasses, to analysis by fire or by solvents. Jefferson's published opinions foreshadowed centuries of inhumane medical experimentation on the Black American body. In Medical Apartheid, author Harriet Washington describes how, while working on an antebellum Georgia slave plantation, Dr. W.H. Robert justified amputating the leg of a 15-year-old enslaved girl who suffered from only minor injuries because amputating the limb of a slave was a matter of comparatively little importance. Students should hesitate much less to remove a limb if he be slave than if he be a free man, and especially a white man. More than a century later, a 2008 survey of Medicare claims found that in Louisiana, Mississippi, and South Carolina, in patients who have diabetes and peripheral artery disease, the rate of leg amputation in Black people is 5 times higher than that of white people. Let's begin to look locally. Historians have concluded that upon its construction in 1892, Grady Memorial Hospital was intended for whites only. Grady is the namesake of Henry W. Grady, known as the father of the New South for his speeches and newspaper columns, which attracted Northern investment in the South's emerging industrial economy after the Civil War. However, his vision for the New South also consisted of resistance of the Black race at all points, and I'm quoting, "because the white race is the superior race." When it opened, Grady Hospital did have wards for Black patients in a separate building. Ultimately, Grady was the last public institution in Atlanta to integrate during the Civil Rights Movement in 1964. In the decades leading up to desegregation of both hospital staff and patient wards, the overall mortality rate for Black Atlantans was twice that of white Atlantans. The infant mortality rate was twice that of whites, and the maternal mortality rate of Black mothers in Atlanta was 5 times that of white mothers. For medical trainees, whites could attend Emory Medical School and choose from 5 hospitals for their internship, while Black students had to leave Atlanta for medical school and could only intern at Hughes Spalding Pavilion, a hospital for Black Atlantans who did not qualify for the free care at Grady. In 1958, this amounted to 2 training spots for Black trainees out of Georgia's 881 total residency, internship, and general practice specialty training positions. Even after Congress passed the Civil Rights Act, hospitals employed policies to obstruct the development of Black physicians. At Grady, only Emory faculty and trainees, in other words, white men, could admit patients. At Crawford Long Hospital, which is now Emory Midtown, applicants for staff positions were required to obtain a letter of recommendation from a current staff member, a staff of all white men who were unlikely to recommend a Black applicant. As recently as 1988, Morehouse School of Medicine, known as the South's leading trainer of Black physicians, advocated for renovation of Hughes Spalding Pavilion, or HSP. Instead, the Fulton DeKalb Hospital Authority chose to close HSP that year. During that time, the Atlanta Constitution newspaper reported that the Grady administration has failed over the years to provide the sophisticated medical equipment HSP needed to attract more patients. Summarizing the conflict, Michael Lomax, chairman of the predominantly Black Fulton County Commission, stated that the closing of HSP illustrated how the hospital authority is not interested in the needs of the Black community. While policies do continue to change and leadership begins to better represent patient populations, there is still much work to be done. In the article, Hidden in Plain Sight, Reconsidering the Use of Race Correction in Clinical Algorithms, authors outlined over a dozen clinical tools when utilized by physicians to this day, apply an adjustment to measurements and results based on the race of the patients. The authors urge readers to scrutinize these tools as they feel strongly that these adjustments have the potential to perpetuate and even amplify race-based health inequities. Students, specifically students of color, continue to lead change. From the Atlanta student movement, which picketed outside Grady in 1961 with posters very similar to these, and were instrumental in the hospital's ultimate desegregation, to Emory's and Morehouse's Student National Medical Association, who worked with Metro Atlanta governments in 2020 to declare racism a public health crisis. The steps forward are not possible without an awareness and appreciation for all the past crimes, mistakes, and lives lost due to the long history of racism in American medical practice. Thank you, everybody, for listening. And I'd now like to pass the virtual microphone to Dr. Ajala, who actually was one of the first attending physicians to train me at Grady Memorial Hospital.
Thank you so much, Sophia. And it was a pleasure working with you. Hello, my name is Khaalisha, and I'm an assistant professor of medicine within a division of hospital medicine. Today's talk is Rounding While Black. We will evaluate structural racism at the bedside. Historically speaking, it has been exposed, but quite known in my community that one could lose their life, witness or suffer emotional trauma, driving while Black, running while Black, sleeping while Black, shopping while Black, walking home while Black, bird watching while Black, or even experiencing home ownership while Black. I am rounding while Black, and I will examine what I see at the bedside and also what I experience as a Black physician. And where do I intersect? I am a Black American of immigrant ancestry. I have a Nigerian father and Nigerian family, and I'm a physician. So what do I encounter on rounds? Well, outside of the clinical scenarios, or at the heart of many of the clinical scenarios that I see with my patients while I work at Grady, I encounter structural racism, the prison industrial complex, redlining, medical education crafted on the enslaved and disenfranchised, job discrimination, the adultification of Black children, racist algorithms, separate and unequal school systems, environmental racism, medical apartheid, and for-profit carceral state. And lastly, I'd like to add microaggressions for sure. First, do no harm. That's what we're taught. But many of us clinicians are not trained to understand how we contribute to the structural foundation of our patients' wellness and illness. And in Dana Bowen Matthews' book, Just Medicine, she talks about where medicine and law intersect, and in many of these cases, how we uphold many of these structural systems that exclude Black and brown people of color. So what is structural violence? It describes social arrangements that put individuals and populations in harm's way. And it's structural because it's embedded in our political and economic systems. And it's violent because it causes harm. Structural racism is a system where public policies, institutional practices, cultural representations, and other norms work in various and often reinforcing ways that perpetuate racial group inequity. And we all have implicit biases. We talk about it a lot. We've heard a lot about it in the past year or so. And we all have these attitudes towards people that are associated with stereotypes. And with them, we have unconscious knowledge. Race and health equity. Many might not connect these two, but in this country and in other places across the world, the color of your skin might determine your experience with health equity, and you might encounter health inequity, which can lead to health disparity. And what we're taught many times is that race occurs with certain diseases, race, age, region, and sometimes this can lead to an unconscious bias that makes us think that one's race is actually linked to a disease process versus it being a social condition. Black physicians have been on the forefront of social justice for quite some time. And in addition to the Freedmen's Bureau, which was created post-Civil War for formerly enslaved Black Americans in order for them to receive medical care, many were still turned away from hospitals for care. So Dr. Daniel Hell Williams, who is the first person to successfully perform heart surgery, created the Providence Hospital in Chicago, and is pictured there. And he was a part of the Black hospital movement, which was a response to legalize discrimination against Black people who were not able to be seen in hospitals. You can't take a human being and teach him that another human being is a second-rate human being and expect him to respond as rapidly as he's going to respond to a first-rate human being. I'm calling it a timing factor. The staff responded a few minutes later with a Black patient, and that response probably would continue with the entire treatment. Dr. Asa Yancey, he was the chief of surgery at Hugh Spalding in 1958. He was also medical director. In addition, he was the first Black medical faculty at Emory University School of Medicine and Grady's first Black physician. Speaking of timing factors, inside the hospital, our patients would run a risk if they were Black with response. In addition, the ambulance services that Grady also ran and still run today historically had some problems. So they did have Black ambulances and they had white ambulances. There were just a few Black ambulances. And if a Black person were to call and say, I need an ambulance, 911 kind of thing, I have an emergency, well, if there were no Black ambulances available, that person would have to wait, even if there were a host of white ambulances available. So that timing factor would also affect the lives of Black Americans. I couldn't put anybody in Grady Hospital because of segregation. I couldn't even visit. There is a doctor, you lost your patient at the front door. Dr. Homer Nash, 1910. Black people have been subject to inferior healthcare access and delivery and have consequently experienced worse health outcomes since the inception of slavery in the American colonies. Here, we have to examine the ghosts of Tulsa, Oklahoma and structural racism because this year is 2021, and in 1921, Tulsa, Oklahoma suffered the crime of the Tulsa Massacre against Black constituents who lived in the Greenwood area. And today we still see its effects where 33% live within poverty versus 13.4% of white Tulsans. And this is not unlike many American cities. This article here actually takes a deep dive. A century after the Tulsa Massacre, inequities in medical infrastructure drive the health gap. There are many Tulsans who can be directly linked through lineage to those who had suffered the Tulsa Massacre that were not driven out to other states. They suffer heart disease, lung disease, diabetes, heart attacks, and health inequity persists. We also have a lasting national legacy of poverty in this country for Black Americans, where we remain at the lowest median household income. And it doesn't stop there. So many say in America, if you own a home, that's the American dream and it's the path to wealth. Well, with redlining and poor poverty appraisals, with redlining and poor appraisals, many African Americans still suffer where they do own homes, but their homes are deemed worth less because of the color of their skin, and this still happens today. This article was actually posted in March 2021. And redlining, as many of us know, were government-sanctioned policies that allowed banks to not loan to African Americans, or for certain neighborhoods to not allow African Americans to move into those neighborhoods. And many were concentrated in what are called project housing. Poverty and environmental racism definitely affects many of our patients, because poverty already isn't a risk factor for being unwell. However, if you are poor and you are Black, you are likely, whether in rural settings or in city or urban settings, to be exposed to bus fumes, to be exposed to living near factories where there's dumping. And this, in a lot of cases, for instance, in Baltimore, you have a higher rate of asthma amongst Black Americans who live in the inner city due to roaches and due to living in urban areas. And then you'll see higher cancer rates as well within rural areas where Black Americans live. Beyond medical mistrust. Many of us are in two pandemics, and we are looking at racism as a public health crisis, and we're looking at COVID-19. And there is vaccine hesitancy, but we must look deeper. There are historical injustices in medicine. And as we see Mrs. Henrietta Lacks, her cells, the HeLa cells, or cancer cells that were pulled from her body and used for medical research without her family's consent or her consent or knowledge. And her family's also still not able to profit in any way from that. There's been the Tuskegee syphilis experiment. You do the eugenics board in North Carolina, where there were forced sterilizations of Black women. And as you've seen in the prior picture, J. Marion Sims, who would perform surgical experimentation on Black women, and he's the father of obstetrics and gynecology. Serena Williams and Black maternal mortality. This is important because, as noted by student Dr. Stylianos, Black women are 2 or more times likely to die during or just after childbirth because we're not heard. Someone once said, listen to Black women, and they meant it in another context, but I would say in the clinical context, and when you go behind that exam door, please listen. Our patients' fears are valid. We must understand this. There's a Tuskegee experiment and the others that I've listed, and daily, many patients feel as though they're not being heard. They may experience racism or discrimination or implicit or explicit bias when they come into our clinics and our hospitals. And so our patients' fears are valid. And as a physician, we face microaggressions many times. And this article here points that out. And I have questions that I face many times. Are you the real doctor? Are you my doctor? Are you transport? Can you get my ice? And as much as I definitely don't mind helping my patients, as many of my who look like me, we love to help our patients, but the assumption that I'm not the real doctor, it takes its toll and it has its effects. However, when we have trainees and medical students, we have to acknowledge that this is a real thing, and we have to acknowledge their feelings around it, and we have to discuss with them these implications and look at ways that we systematically can possibly prevent this. Black physicians only make up 5% of physicians in the US, and we need to do more to recruit, retain Black physicians. A pathology of racism, a call to desegregate teaching hospitals. Dr. Del Rio sent out this article not too long ago, and this article was posted, I think, on the 23rd. And this is groundbreaking to me in that this is taking a look at what we've always considered normal, the pathology, the advanced pathology that we see in teaching hospitals such as Grady. Why is that normal? A lot of this advanced pathology is us normalizing, or what we call advanced pathology, in a sense to make it sound interesting, to draw residents to choose our programs. We need to look at this a little bit deeper because it's the social determinants of health. It's the health inequities that lead to health disparities that have led to our patients coming in these critical conditions that we would consider that would happen in other societies where they might have impoverished governments. But what we're seeing here is in a pretty wealthy country where we all should have access to healthcare. But because of what we're seeing in our patients, we've grown quite used to seeing advanced pathology in Grady, but we may not see it in other hospitals and we don't call it out. So we need to address social determinants of health, structural racism, and structural violence, and make some changes within the medical system as well as within education. So we're done rounding while Black. We're done with rounds, but what's next?
Okay, I think that concludes the presentation. Is that correct? Am I missing?
No.
anything? Okay, wonderful. Thank you. Thank you so much. Let's give our hand to our panelists and those that are online. I think you can send your class through the chat.
We have one more presentation.
Oh, my apologies.
That's all right. That's all
Yes.
right. That's all right. It's okay. It happens. I'm Dr. Heron, and I am going to conclude the conversation as we began with acknowledging our past and to answer Dr. Ajala's question as to what is next. And so what we want to do is think about where we are from the past as we move to the present. And as we move to the present, what we began in the School of Medicine to do is really think about what this looks like, how this looks like, and why we must continue to rest and understand our past to acknowledge our future. As we do that, what we determined is from last year at the National Medical Association's 125th conference, which was to be in Atlanta, our students from our School of Medicine and Emory University got together to create a presentation for us to think about how do we acknowledge our past to empower our future. What we did in doing so was create a Prezi presentation that you can find on our School of Medicine website, Office of Diversity and Inclusion front page, where we can encourage you to help us explore our history, because it is through this history where we acknowledge, honor, and recognize and celebrate African-American physicians for their leadership, scholarship, and service, we can start to understand how we can move forward. This Prezi presentation, which looked at 184 years of progress, started with Emory's history and Emory's realities of being chartered in Oxford, Georgia, December 10th, 1836, moving to today, where we are celebrating and thinking about Emory's history in slavery and dispossession. Under the leadership of Dr. Carol Henderson and Dean Yolanda, who were from our librarian, we are enthralled and committed to do this work. As we are so in the School of Medicine, where we looked historically of where we've been from the lens of African Americans, both the celebrations and the challenges, to where we are today. And this interactive presentation really starts with what we mentioned, with Emory University coming out of Oxford College in 1836, paid for and built on the backs of slaves. We fast forward and recognize that Emory had its first commencement at Emory College in 1840. And we are then clear and painfully aware that Bishop James Andrew came under scrutiny for owning slaves, in particular Miss Kitty, who I know has been recognized and discussed in this symposium. As we marched forward, germane to the School of Medicine in 1854, Atlanta Medical College is founded. And as we moved forward, we know 50 years later, after writing an essay titled "The Negro, Another View," who criticized lynching in Georgia, Professor Andrew Sled was forced to resign from Emory College. Our history. Emory University is chartered and renamed Emory University School of Medicine in 1915. And 40 years later, almost, the US Supreme Court rules segregation in public schools unconstitutional in Brown versus Board of Education. Why does it matter and why is it important as we try to have restorative justice and move forward? It was in 1959 that Marion Gerald Hood applied to the School of Medicine and received that infamous rejection letter solely based on his race. It's dated 1959, as you can see there, with an apology for not allowing him admission and the return of his $5 application fee. So what does that mean as we consider how we are going to move forward to acknowledge our past, present, and future? Well, we tried and we started to do so this year by apologizing to Dr. Hood around Juneteenth, which we know celebrates when African Americans believed they were freed from slavery. Dr. Hood's story was circulated nationally in the New York Times, and he talked about moving forward. It's not about being rejected from Emory, because that was not his story. His story was about accomplishment and meeting his goal in becoming a storied and lauded obstetric and gynecologist right here in Georgia. And his story continues through the Academy for American Academy of Medical Colleges, who this year, this November, will feature him in a video to talk about his legacy and what he was able to accomplish despite his rejection. History, past and present. And Dr. Hood and I sat together right here on the very lawns of Emory University to discuss the progress we have made and what we must do in our actionable educational initiative that is being created in the School of Medicine to move us forward to empower our future. This actionable educational initiative is part of our strategic initiative to move us forward in the School of Medicine on these 4 themes, including awareness, learning, and growing, inclusive culture and climate, community engagement, research, and innovation. We will then start with awareness, learning, and growing. We are so grateful for the presentations that you've already heard that spoke about the need to become anti-racist, the realities of implicit bias, microaggressions, how as bystanders and upstanders, we should respond and react in kind. And more importantly, grounded in all of this is the history. So our goal of the Actionable Education Initiative is to design and implement an educational portfolio for our learners, our staff, our faculty that infuses principles and competencies of equity, cultural humility, anti-racism, bias mitigation, and respect for all members of our community. The history pillar is absolutely foundational. And I would like to thank publicly Tyrese Hinkins-Jones and Nate Spell, who co-chair the history pillar of this initiative, who after 8 months of deliberation, discussion, and I would dare say conversation that could be quite provocative, put forth goals and objectives in recommendations, both short, mid, and long-term to execute this goal. So what are those goals under the history pillar? 1, to propose educational programs and resources that support organizational goals of this pillar of history. 2, ensure that the recommended programs and resources show the impact of racism in the history of Emory University School of Medicine, Emory University, and the significance of Grady Memorial Hospital, Morehouse School of Medicine, and the city of Atlanta. We hope in sharing this history, we are all inclusive for everyone, all groups and communities, to include, but not limited to African American, Latinx, Native Americans, Asian American, Pacific Islanders, LGBTQ, and women. And we want to be laser focused in how we do this, because our future initiatives and our next steps includes a planning committee of individuals who are not afraid to step out and step in, to think about how to execute these goals. How do we prioritize what needs to be done? And most importantly, monitor progress and keep us accountable. Because in the School of Medicine, as we speak, sits this time capsule to be opened in the year 2054, empowering our future. At this bicentennial of the Emory University School of Medicine, what do we see and who will we be as an institution? As we walk through the storied halls of Emory University and into the School of Medicine, will we continue to partner with Morehouse School of Medicine, which we must do, and Emory Healthcare, where our trainees and our faculty and our staff go, in partnership with Grady Memorial Hospital, where we know has its own history of racism and segregation, just in fact by how it's built as an H, where one side was for Blacks, the other for white. And we must do this in partnership together, because the city of Atlanta is counting on us. And we have to ground our history to ensure that when we empower our future, Dr. Hood and myself, when we walk the storied grounds of Emory University, we can look down hand in hand and be proud of the progress we have made. I would like to thank our team listed here, who will take the baton and move us forward so that as we acknowledge our past, we will empower our future. Thank you.
Thank you. Now's the right time to say thank you to our panelists and those who joined us. We have about 5 minutes for questions, so if anybody has one in the room, I can, please wait for the mic so that the folks online can also hear you if anybody has a question. We do have one comment in the chat from Rachel Breckus. Please forgive me if I mispronounced your name. Recently saw an article in Science Advances on racial attention gap. White people in every profession must realize the implications of that article. White people's disattention has such harmful consequences in medicine, it's life and death. Thank you for that comment. Any other questions for the panelists?
If I may respond to Rachel, this is why foundationally understanding the history, as eloquently stated by medical student Stylianos and by my colleague, Dr. Ajala, is so incredibly important. I think if everyone understands this history, there would be, I hope, a clear appreciation for why we must collectively move forward and be intentional about addressing these real disparities and health inequities. So it is through and why we talk about the history, because many of us don't know that history. And when we know that history, it is very difficult, I would dare say, to turn a blind eye and not be responsive to that history. Thank you.
Thank you. Any other questions?
Well, I have a question for Dr. Heron. What are your thoughts on what seems to be a bit of fatigue I notice amongst many of us who have witnessed both pandemics of, racism being a public health crisis and COVID-19. I think that, with all the protests and all the other things that happened after George Floyd, there may be some who might not have the interest they once had concerning anti-racism work and justice, social justice, and bringing that, into the healthcare space. What are your thoughts on that?
Great question, Dr. Ajala. And the reality is we must continue to fight. When I think about the ancestors on whose shoulders we stand, including John Lewis, Martin Luther King, and all the people that you've mentioned who I would dare say truly set the stage and the understanding and suffered the pain to get us where we are today, where we can even utter words such as racism and white supremacy. We have to understand that it is brick by brick, person by person, as we deconstruct and reconstruct the house we want to see at Emory University School of Medicine. And so while the fatigue is there, it is okay to step back, pause individually and collectively to breathe and reset, but never lose sight that we have to continue for generations to come. It is acknowledging our past, empowering our future. That is the title of this session. And we have to maintain the commitment to this. So as we empower generations to come, they can continue to build on the critical mass needed to move us forward collectively in our humanity. For everyone wins when we are all accepted for who we are and treated with equity, dignity, and respect. And it's okay to say that you're tired. It's more than fine. But you reach out, you find others who share that walk, but also be encouraged by the incredible amount of work that is happening, never before seen, across our institution. And as a woman of faith and always filled with hope, I get up another day to do what I can and take it with me. You can reach out to me anytime, Khaalisha.
We have one more comment from the chat, and I think that will close us out. From Frank Richards. I note one of the pillars is research. How do we encourage, given the history of abusive research, to get African Americans into clinical studies? They are underrepresented in these studies, and I, for one, as an African American physician, see this as a problem.
I mean, I don't want to, take over, and I'd love to relate it, but the short answer is to have representation of African Americans, people of color, people who are in marginalized groups, to lead studies, to lead in leadership positions, whether it's their deans or vice chairs or scientists. I mean, we start to see that where members of the National Academy of Medicine, for example, who are both African American and Latinx, speak to the public because they see and trust individuals who can engage and help them move forward. It's the boots on the ground. And Emory Hospital, Emory University, and Emory Healthcare, for example, have done an incredible, aggressive communication to patients who are marginalized, Black and brown people, around the COVID vaccine, for example, going into communities and engaging in that way. And so as Black and brown people see individuals who look like them and who are absolutely passionate about what they do, they will invariably trust and hopefully engage in the research that is coming down the pike. And there is national attention to this. The National Academy of Sciences under Francis Collins have made a bold public statement about racism and anti-racism and the need to engage African Americans and other people of color. in doing research and being a part of studies. We are pushing that as well in the School of Medicine under our research and discovery pillar to ensure that we're being inclusive and engaging in that space. So it is a movement and something that we have to be a part of and visibly a part of as people of color, to be able to pull people in so that they trust us in what we're trying to accomplish. I hope that answers your question. Dr. Ajala, any other thoughts on that?
No, I think you said it well. I was answering questions in the chat, typing your questions in the chat because of our time. Someone had asked about promotion and access to basically promotion with underrepresented minorities. And I spoke about that particular program that we have at Emory and how Dr. Jada Bussey-Jones, Dr. Manning, yourself, and others are doing well with creating space that's actually structured by Emory to help those persons of color, Black Americans who are physicians to advance for promotion, but also there are other programs such as our, well, I guess newly released, but definitely in place, our program with our queens, you know, our African American Women Collective for the physicians and that are African American women. There's a sense of mentorship that happens there, in addition to just sisterhood and being able to talk about what we face. So those things are in place. I'll just leave it at that. I know we're short on time, so I'm trying to. So yes, and then there's one more question in the chat. I don't know if we have time for that or.
I think we are actually out of time, but I thank you all so much for your research, your scholarship, and your work as healthcare professionals, doing very difficult, arduous, maybe even thankless work, but we appreciate you. And I encourage you all to continue the conversation in your professions, in your communities. And thank you all so much for attending. We'll make way for the next session. Thank you.
Thank you.
Thank you.